Welcome to medical school. Sounds like the start of the Indy 500. I've been waiting all day to say that, so thanks for putting up with me. So tonight's seminar is the third of our four spring seminars in community medical school, and we offer these sessions in the fall and the spring. And these are sponsored by the Larner College of Medicine and the University of Vermont Medical Center. And they're really designed to kind of reach out to our community to help you understand and get to know some of our faculty and educators who have experience and maybe experts in specific fields. And they'll talk about not only the science, but also, and you'll hear this today, the art of timely health topics. And so really pleased that many of you were able to be here tonight, and I'm going to have the great fortune to introduce our speaker. Speaking of myself, my name is Tom Peterson. I'm the chair of family medicine at the University of Vermont College of Medicine and at the Medical Center. I'm a practicing family physician for over 30 years in Colchester, Vermont, and here at the hospital. And it's really a great opportunity to kind of see so many of you here at the college. So tonight's speaker is Dr. Robert Gramling, who is the Holly and Bob Miller Inaugural Endowed Chair in Palliative Medicine. And he's an associate professor of family medicine and chief of the Palliative Medicine Division. Our distinguished speaker, who is seated right here, joined our faculty last spring, actually just 11 months ago, almost to the day, from the University of Rochester School of Medicine and Dentistry, where he was an associate professor of family medicine, also of public health and nursing. And he served as a research and fellowship director for the Palliative Care Division. And he also was the chair of the Curriculum Instruction Committee for the entire School of Medicine, which is a very big deal. Bob received his BA at Colby College, his physician degree, his MD degree at Dartmouth Medical College right down the road. He did his residency at the Maine Dartmouth Family Medicine Residency, and then he received his doctorate in epidemiology from Boston University. So actually he is a doctor. So Dr. Gramling is also a winner of the Fulbright Scholarship in 2015. He studied in Kyoto, Japan, and also in the same year he was a visiting fellow at Cambridge University. Dr. Gramling has an extensive portfolio of clinical care and teaching, and notably also in research and advancing the science of palliative medicine, and currently is funded by the American Cancer Society. Since joining here, our organization in the last 11 months, he really has profoundly enhanced palliative care and hospice care, not only in our hospital, but also broadly in our community and region. He's helped expand our workforce. He's developed really 7-day expertise. He's enhanced our ability to provide both inpatient and outpatient consultations, and also in the emergency room, and really has led significant efforts to really have important conversations in primary care offices around the region, so that we really have the knowledge to capably do what is really actually a very natural discussion all across the region. It's very important. Many people were influential in bringing Bob to the University of Vermont and to the Burlington community, and notably I'd like to call out Holly Miller, who's right behind Bob. So Holly and Bob have supported palliative medicine not only through the very significant event of creating this endowed chair, but really they, like many of you, have been significant leaders, tireless leaders in the community for hospice and palliative care, and that's really important. We've had great support from the Madison Dean Initiative, from the visiting nurses, and from many of you in this audience, and I profoundly thank you. So thank you for attending. Dr. Gramling's topic tonight will be Conversations in Serious Illness, Improving Clinician, Patient, and Family Communication. Welcome and thank you, Bob.
Thank you, Tom. I wish upon you the good fortune of having such a wonderful boss as I do, and thank you, Tom. You made my transition exciting. And also, I don't think anybody from my team is here right now, but I stepped into a role with a fabulous group of palliative care folks here, and they have been just inspiring to me as we grow this idea at UVM. So I just wanted to say that it's a phenomenal group of people. And if you have had a role in agitating for palliative care, for being a collaborator, for helping this idea to grow that we can care well for people who are seriously ill and near the end of their lives, just know it and know that we are grateful to you for your efforts, and thanks for coming here tonight. So I changed the title. So the title's a little different than what Tom said, but it's the same idea, is Serious Illness Conversations. I'm going to talk a little bit about what they are and get to some of the lingo that we tend to use a lot. And it's really about understanding and disseminating high-quality communication, something we can all value and all recognize both when it happens and when it doesn't happen. I have no ethical or financial conflicts to report, as we always say this in presentations that involve some research data like we do. I have other conflicts. If you have time, we'll grab a coffee and we can chat about them. But palliative care. So let's jump right in. So palliative care means patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. So this is the National Consensus Project definition that's been adopted by Medicare, and I think you're going to see it in multiple places. But what is unique to this definition is that last word, suffering. So in the context of medical education, there are few disciplines that have the honor of being focused on this concept of suffering as opposed to disease. And they're not always mutually exclusive, but they're different things. And so to understand what suffering is, I carried this around in my backpack when I was sitting in your seats, although not here, at our partner down the road. Eric Cassell wrote a paper in '82 in New England Journal of Medicine that was the nature of suffering and the goals of medicine. And it was pivotal for me to read this paper, be going through my education, and to be finding in it a substance, something that really, really drove me. Was this concept of suffering. And Eric does a really nice job of defining it. Suffering is experienced by persons, not merely bodies, and has its sources and challenges that threaten the intactness of the person as a complex social and psychological entity. Now, this definition has stood the test of time to be a practical way of addressing what it might mean. Does anybody know what this is? Take a look at this picture. And I think I have some friends in the audience who have seen me talk before and might have seen this slide before, and you're welcome to say it. Any ideas of what this is a picture of? Oh, I'm sorry, I forgot to mention, I asked you a question and I should have prepared you. I have horrible vision. So I don't respond well to subtle cues. And so please feel free to just go like this and say, hey, Bob, or just speak it out or stand up. It's perfectly fine for me. In fact, it helps me. Any ideas what this is?
Pain.
Pain. Wonderful. So that analogy really jumps right out to you. That's really wonderful. No, it's lovely.
Exponential information age. More information on the same topic.
Perfect.
What was that?
Exponential information age. Kind of almost a symbol of complexity a little bit. It seems like. Yeah. So these are crayons. So 100 years ago, when we had to make a choice, we had 8 of them, right? And it made it relatively straightforward for those of us who could see the differences in those colors. That's not the world we live in right now. If you're really, really lucky, you've got the 1024 version of your crayons. I don't know if that's lucky or not, but you got a lot of choices, right? And so Eric Cassell goes on to say that failure to understand the nature of suffering can result in medical intervention that, though technically adequate, not only fails to relieve suffering, but becomes a source of suffering itself. So this complexity and the choices we make about medical treatments are not separate from a concept of suffering. They're intertwined in this thing, this beautiful thing that we get to turn towards in the work that we do. Over the last, since I'm a researcher, I have to show you a graph. So this is, I think, maybe the 1 or 2 you're going to get. Palliative care has really exploded over the last 20 years. And one of the main reason that we're asked and invited into people's care is for what's called goals of care conversations. Now that's code. Anybody work in a field that has a code, some kind of lingo that really no one else exactly knows what you're talking about, but use it a lot? Well, this is what this is for us. A goals of care conversation is saying that somebody, whether it's the patient, their family, their friend, their technician, their nurse, their physician, their social worker, somebody involved in that person's life at the moment of, most times, hospitalization, is concerned that this person is suffering or is at risk of suffering given the stuff that's happening. And we're being asked to come sit with that and help understand what suffering means to this human being and what the crayons look like. Not to go too far with a silly metaphor, but that there are lots of choices we're making in this context. So this is the focus of the rest of this talk today, our goals of care conversations. And we can all share that code now that you've been indoctrinated into knowing what it is. So I say 75 minutes. We might go a little shorter to make sure we allow enough time for questions and answers. I really want to hear what's important to you and make sure we have space for that. But I'm going to give a very brief state of the science. It's going to be on one slide, so don't worry about too much of the science talk. But then go right into how are we going about learning about what it is in these goals of care conversations that matters to people, and how are we taking that and teaching it and disseminating it? So we're making use of it in almost near real time. One of the criticisms about research is that when we find something new, on average, there's a 14 to 17-year delay before that actually gets adopted into practice. And so one of the things we're committed to doing is learning as we go and implementing what we can and responsibly do as we learn more about goals of care conversations. And then leave time for our conversation. Is that an okay plan? I love asking that because I have yet to have anyone say, no, I really don't like that plan. Let's come up with something else. Someone's going to do it someday, and then I'm really in trouble. So the state of the science. So this is what we know, what we can put our nickel down on, because there's been enough observations out there and enough studies that are consistent. And so we're finding that palliative care consultation in serious illness improves quality of life and promotes goal-concordant treatment. And goal-concordant treatment is another code word, but what it's really getting at is treatments, particularly at end of life, whenever and however we define that, are matching what's important to that human being, whether we call it values, preferences, or goals, that there's a match there. That's what this is referring to. And the goals of care conversations are our primary procedure. That's what we do. We don't do cardiac caths. We don't do other stuff like that, but we do this thing called the goals of care conversation. And so that is what we need to understand. But we don't right now. The science is early, so we know quite little empirically about what happens in these conversations that is of value. What promotes quality of life? What promotes goal-concordant care? I might believe what works. My colleague might believe what works. And we might not believe the same things. So that's one of the beauties of being able to try to study this and have the privilege of studying this, is begin to understand it a little bit. So that's what we're going to talk about. Now, one of the questions is that, well, so what? It's working, right? So why do you have to know what happens in a goals of care conversation? Because we know that if you're having palliative care consults, well, there's a few reasons. One is we got to get better at it. We need to understand what we're doing so we can improve. We have not reached how good this can be. We also have to reach more people. Palliative care, as it's currently modeled, is a scarce resource. The estimates are for every palliative care physician, there'll be 23,000 people who, in this country, in the next 5 years, who would meet eligibility for a palliative care consultation. And we only have 200 slots per year in fellowship creating new palliative care physicians. So the math just doesn't work. So how we disseminate this, how we scale this up, means we need to understand what's working, not just calling it palliative care. So that's the mission of our lab here, the Vermont Conversation Lab, is our team, our mission is to understand and to disseminate high-quality conversations in serious illness. So I'm just going to give you a little bit of flavor of how we do that, how we go about doing that, and what might be let's go about how we go about this. So we have we're fortunate to have a current study that's just entering the analysis phase, where we observed people with advanced cancer who were referred for palliative care at University of Rochester or the University of California at San Francisco. And we interviewed them before palliative care consultation. We observed, we had a nurse anthropologist observing the conversations. We recorded the conversations, up to 3 of them. We interviewed patients and families after, and then we followed these people for the rest of their lives or 6 months, whichever was shorter. And we had 240 participants, patient participants, and 54 palliative care clinician participants that contributed 363 conversations at about 40 minutes per conversation. So that's a lot of listening as we study them. And that's exactly what we do. So in order to understand what it is about a goals of care conversation that is of value, we need to observe it. And we need to try to observe as best we can without changing it. And so one of the things that we do is we have coders listen to conversation. These are people who are trained to find something we're looking for. And I'm going to give you an example of that in a couple of slides of one of the things we do. We measure lots of stuff that are conceptually important to human interaction in time suffering, types of content of information, the way it's delivered, the responsiveness to people's interactions. We actually use music students because the composition music students are really good at listening for things. They're used to listening for a B flat in a symphony and finding it. So essentially, that's what we're asking them to do. They listen to 40 minutes of a conversation and listen for the occurrence of something. And when we train them enough and develop our rules for what counts and what doesn't count in a way that 2 people are finding the same events, we call that reliability, meaning what we're finding is reliably findable. And then to understand what matters, not just what happens, but what matters, we take these multiple dimensions of a conversation that we're looking at and begin to look at which predict outcomes of value, the types of things that are important to us as human beings when we're suffering. And now there are many important outcomes, and I think that we could probably come up with a really robust list. This is one that we've really come to adore on our team, and one that that is fundamentally, when we think of this concept of patient-centeredness. Has anyone heard that term, patient-centeredness? Well, there's going to be, it's a lovely thing, right? If you ask, there's different camps of patient-centeredness when you get into the science, and everyone measures it a little bit differently. Some things count, some things don't count. But what's the commonality in all of these different definitions is the sense that some kind of thing you're doing, whether we call it communication or we call it environment or whatever it is, that's promoting this person feeling heard and feeling understood in their care environment. And so that's what we went right after. And so this is asking, for those of you who might not be able to read it in the back, was over the past 2 days, how much have you felt heard and understood by the doctors, nurses, and hospital staff? Completely, quite a bit, moderately, slightly, or not at all. If anyone's interested in how, by the way, how we developed this item and how it's being used, it's been adopted nationally as a quality indicator for palliative care. Our paper's on the back table if you just want to read about it or have some fun with it. So what we do is I'm going to give an example of one thing, one phenomena that we're looking at, and it's going to be compassion. Because early on in our work, maybe it was about 15 years ago or so, there was a lot of work going on in concepts of empathy, that trying to train physicians what we call empathic opportunities. When a person who is hurting expresses that they're hurting, usually in some form of emotional, whether it's fear, anger, sadness, whatever it is, a lot of the people in communication science would recognize that a lot of physicians don't seem to respond to that or don't seem to know what to do with that. And so a lot of the training was around empathy. And empathy can be defined as being able to feel another's pain. That's one functional, or joy, it doesn't have to be pain. To experience this with another is one model of it. But we were going after compassion because what we've learned, both from neuroscience and from early work in palliative care, is that when you add a little piece to that, when it's not, the goal is not for me to feel your pain and stop there, because now we're just both in pain, right? My job is to help. And so I need to be able to feel that well enough to know enough of what you're going through as a human being, that you are suffering. But I need to channel that into my love for you, my care for you. And yes, I use the word love with medical students, and sometimes they'll fall off their chairs at first. But we get there. And to express that I care about you and recognize your suffering, and that I intend to do something about it. Even that intention. That brings it into something called compassion. And the neuroscience shows that when you train people to be empathic, it triggers parts of the brain that ultimately cause dread and pain. When you train people in compassion, the parts of your brain that lights up are joy. And so when you're looking for something sustainable to do and sustainable to treat, it's really compassion training. So that's what we went after in these conversations. So the way we do it is first we need to come up with a definition. There's lots of definitions of what compassion is. Roshi Halifax is a Buddhist priest at the Santa Fe Institute. He's also a compassion scholar. She defines it as compassion can thus be described as having two main components: the affective feeling of caring for one who is suffering and the motivation to relieve suffering. What's beautiful about this type of definition is we can go after this from a coding point of view. Now, when our music students are listening to a conversation, we purposefully train people to say, don't try to be mind readers, because we're all going to read people's minds differently. Just go after what's said, what's put out there in a conversation. And so to track on this definition, we train our coders to find an expression of caring awareness of suffering and a motivation to relieve that suffering. And I'll show you an example of what we find. So this is a 71-year-old person with late-stage heart failure. And this comes in about 20 minutes into a conversation after this person has been able to express some of the fears they have about not being able to get enough air and what does this mean. And this is an excerpt that comes out in the conversation that we coded as compassion, and I'll show you right where. This is a palliative care physician. This is one of my jobs here, while we're getting a chance to know each other, however long that time is to help make sure all of your energies and all of your fight is going in the direction you want them to go in. As your doctor, I am here for you. From what you've told me, I know your struggle has been hard, and I want to help in whatever way I can for you. So that's an example of what would count as a compassionate statement. And what we found was really, for me, heartening and inspiring. For lots of the communication work in serious illness, when we study this, you don't see a lot of response to suffering like this. What we saw is an extraordinarily high response with compassionate responses to when a person expresses fear or anxiety or sadness or any emotional expression of suffering, that the majority of responses were in the realm of compassion. Not all, and we'll get to why that might be. But there was something else that we were noticing. And so this study was done, but our coders, we also had them keep a little notebook. So say, this didn't fit. There was something going on here. It didn't fit my definition, so it didn't count, but it was interesting. And so their notebooks would just be at 21 minutes in conversation 111. I want to come back to that. And so we do. We come back to it. And what they were finding is this. This is a 72-year-old person with metastatic lung cancer. This is about half hour into the conversation. For the preceding 15 minutes, this person was an evangelical, born-again Christian and had been trying subtly and not so subtly sometimes to convert this physician to be saved by Jesus Christ. If you want to see a faster way to get a physician to leave a room, it's hard to come up with it. But what we saw was this, and the physician did not share the same religious background. So the patient, at the end of, kind of towards the end of this, is my fellow Christians come to visit, and they see me. And the physician, you speak about it so beautifully. Thank you for sharing with me. It's a warm feeling. And so the rest of the conversation then goes on to discussing existential and spiritual concerns and a really important decision making. But what this was an example of, and we saw this type of thing with lots of topics that would be traditionally uncomfortable or traditionally not so sure what to do with, whether it's death, dying, whatever it happens to be. And what we were finding out is this is really something that fits into something that Thich Nhat Hanh, as far as I know, was the first to put into a book, a Tibetan Buddhist priest. But now Ron Epstein and Tony Bach wrote about it in JAMA and brought it into the medical vernacular, is this concept of turning towards. And turning towards means recognizing suffering, becoming curious about the patient's experience, and intentionally becoming more present and engaged. And so that's this thing that we were seeing. And there was another thing that we were seeing, is the ways that we did that. I say we, because I was a participant. I didn't feel like I could do this study without also exposing myself to the vulnerability of having someone watch me and tape me. And because of the methods for the study, me being a participant didn't threaten the validity of it at all. But what was interesting is one of the things that we've found in the past in many studies is that when it comes to communication in medical settings, that people have a style. And that style sometimes can become the one thing they use over and over and over and over again, even when that style isn't so great in that one setting. But we didn't see that here. We didn't see what you're about to see right now happen. Anybody want a little laugh? Okay, prepare yourself to laugh. This is a friend of mine who's a palliative care researcher at California. And we both study communication. So sometimes we need some examples to say, well, what are we trying to avoid? What is this thing we're talking about?
Please take out the trash. Take out the trash. Hey. Are you listening to me? Take out the trash.
Did you say something?
Yes. I said take out the trash.
Can you think of a nicer way you could ask me to take out the trash?
How about take out the trash, you knucklehead?
You could say, please honey, could you kindly take out the trash? Could you say something about how you are feeling about what we have just discussed?
I'm feeling like hitting you on the head until you take out the trash.
I feel like we are not on the same track. Some people in this situation would be angry. I cannot imagine what it would be like to have a husband like me.
No, you cannot imagine.
I want you to know I will be with you, no matter what happens.
You mean what happens when I dump the trash on your head?
I sense how upset you are feeling about the trash. Maybe you could tell me more about your understanding of where things stand with the trash.
My understanding is that the trash has not been taken out, and you are still talking.
Talking about the trash can be complicated. To make sure I have done a good job explaining about the trash, could you explain what we have just discussed? Would it be all right if I sat down while we talked?
So if I can, if it was hard to hear, I can afterwards show you the trash again. But the beauty of that is it's just such a crisp explanation of things that work when you're in a honey, I'm really concerned about this. I wonder if we can have a chance to sit down and talk about it conversation versus a take out the trash conversation. Compassion and what makes people feel heard and understood looks really different, right? So that's really one of the approaches we take to studying conversations. And one of the things that we saw very clearly, and what this tells us is that we need to be able to not only teach and model and explore the specific types of communication skills and moments in a conversation, but also train this concept of situational, or self and situational awareness. Kind of awareness of what's happening in me when I'm talking or listening, but also what's happening around me. And so we need to be aware of both of those things, because one without the other isn't really going to help very much. We'll be taking out the trash when we should be doing something different. All right. So coaching. We've evolved to use this term in communication training because it really does capture what we're trying to do very well. Words like training and teaching and such may not necessarily do it, because coaching is really about trying to uncover some innate skills that people have, some interests, practice them, and develop them wherever they're starting from. And so we really kind of take an approach to coaching communication that really takes a few steps. One is to model what it is you're trying to coach, or whatever you think it is. Watch a few soccer games. Watch about how some other people do things. Just watch it. And add to an aspect of discovery. Find out what's interesting to you. What is it about the way that conversation just happened that was interesting to you? Identify the skill that the person wants to work on. And then map it conceptually. Say, what is it? What is this skill we're trying to teach, trying to coach? And then practice. And then practice and practice and practice and always practice. So that's how we go about coaching. So we do it a few different ways. One is that on our every 2 weeks we have learners from the School of Medicine, the School of Nursing, from residents in multiple disciplines in family medicine, internal medicine, oncology, anesthesiology, surgery, will rotate with us, and 104 learners every year get a chance to join us for 2 weeks. And a lot of that experience is being able to see conversations that we do and just see them, and then begin to participate. But it does a few things. One is it gives it permission to do something that isn't necessarily what's always modeled. It might look a little different than what people have been exposed to. And helps them when we walk out of a room, ask them, what was interesting in that? What did you find interesting? And just to trigger a little bit of this desire to understand what it is that we're having this conversation. But what we also do is we're fortunate enough to have a week-long required palliative medicine course in the medical school, and a longitudinal course on chronic pain and palliative care in the nursing school that we're invited in to teach. And this is one aspect of it, is we have created a video library. Right now it's 5 videos. My goal is to get to 100. What we do with these videos is we have a homework assignment, or we actually have a lab with the medical students. I have them for a whole week. With the nursing students, I have them for a day, so it's a homework assignment, is to watch 1 or 2. And all you have to do is write down the minute where you found something interesting. When it started, when it stopped, that's it. And what we do then is the rest of the week is we help identify, each small group's going to identify what moment was most interesting to them. They're going to go research it, figure out what it's called. They're going to create a small little presentation to teach their classmates about what this moment was and investigate it. And so without me telling them what's important or not important, they're going to figure it out. And so the beauty is having multiple different clinicians. We're all going to have different styles. And Vivian, who I'm going to introduce you to in a minute, our professional actor, we're going to be fleshing out this video library to have multiple actors, so we can construct a few different scenarios so that people can really get a more robust experience with the multitude of settings that you find yourself in these conversations. But what we did is in the discovery part is that moment. So what I did then, for example, is when they have that moment, in the School of Nursing just had a session a few weeks ago, and they just emailed me their minute when it started, when it stopped, and because I'm a geek, I guess, I put those into a spreadsheet, and they made a little graph with them, just to find out what was interesting. And it was like little peaks on the graph that people were gravitating to a handful of stuff that was interesting. And this is the stuff that was interesting to the nursing students and to the medical students, was almost any parts of the conversation that were talking about what to expect, or anticipatory guidance, or prognosis, or what I expect for how long you might live, what I expect for what it might look like, what I expect medically for the effects of this treatment that you're considering doing. What do I think is going to happen with that? That type of conversation is one piece that was really interesting to the group. The other is a lot of these conversations will have some degree of explicit or implicit terror about death, dying, being dead. What does it mean? This has a piece that is oftentimes part of a lot of our psyche, whether we talk about it or not. And so in this example, we have examples of talking about it. Humor. Oh my God, we can have some humor in this, isn't it? How do you do your job? I can't believe you do this. You're going to go home depressed every night. Not at all. These are really rich human interactions filled with terror, filled with joy, filled with boredom sometimes. They're filled with just stuff, but they're real and they're human and they're vitalizing. And so getting a chance to see that is lovely. Touch. We all did it a little differently. I asked, in our example, I asked if it was okay if I held her hand while we talked. The students thought that was weird, so they called it the awkward moment. They thought, I didn't feel that awkward. Did you? It was lovely to have a conversation about touch. What is it? When can it be helpful? When can it not? When can it be threatening? How do you handle that? And then for the concerns about, gosh, doc, when you can't take away this fluid that's filling in my lungs, am I going to suffocate to death? Is that what's going to happen? Being able to talk about that and be able to address those fears and say, this is the plan of how we're going to handle this, and this is what we need to have in place, and led to talking to her fiance about how we're going to make sure we handle this together. Those are the things that were happening and people were interested in. And the piece of all of these that all of them had some piece of turning towards. And so I'm going to come back to the turning towards now instead of going to these skill sets as an example of what it might mean to map these skills and then to practice them. I'm going to put these, Vivian, I can put these on before they... Don't ever let a doctor touch the bed. We always mess it up, like I'm doing right now. So mapping this concept of turning towards in the coaching. So we did the modeling and we did the discovery. And what I'm doing right now is actually not very good, and I'll tell you why. Is if I know I want to teach this turning towards thing, why would I bother with a discovery thing, right? What happens if they find something else they want to do and I'm not prepared to talk about it? That would not be good. So we really do let it organically go. Today, however, I'm bringing it back and pretend that Bailey, who is going to be our medical student extraordinaire, is going to have been really interested in this thing she's seeing and that we've named turning towards and wants to practice a little bit. So we map it. And now you're all students here. And so we're going to think about what this turning towards thing might mean. And so we take our definition. Turning toward means recognizing suffering and becoming curious about the patient's experience and intentionally becoming more present and engaged. And really break it down and say that one element of this is recognizing suffering. So a conversation, what does that look like? What can suffering be? What is it not? What if I think they're suffering and they're really not? And how do I demonstrate that I'm aware of that? And what we'll do is, I'm not going to do it now because it'll take too much time, but we'd probably take one of these whiteboards, and here we'd come up together with what are some expressions that demonstrate that I'm aware that you're suffering, or I think you are. Anyone want to give an example of something you think might be a nice way of just recognizing, gosh, there's something going on here, I wanted to name it.
Facial expression.
Facial expression, yeah, so it doesn't have to be verbal, right? For a guy who doesn't see well, I don't necessarily do that if you're beyond 5 feet. So in fact, when I was little, I had to be aware real early that people who I didn't think could see me really could see me. So when I was like Dad, it wasn't, my mom had to say, Bobby, they can see you. Stop doing that. All right. So then, so one can be facial expression, nonverbal, where how you stand, my openness, my coming to, physically turning towards, literally. Absolutely, as long as I don't scare you. And the next step is going to be being curious. Well, that's kind of weird, right? Bailey's curious kind of weird. I mean, I'm not training you to be a voyeur or something, right? I mean, curiosity? What's about that? Well, this idea of curiosity comes from something that we'll refer to as this concept of beginner's mind. Is that if we're all trained to be experts, right? So when you get out of here after 4 years, you're going to get your doctoral degree, and everyone's going to consider you an expert. And if you pretend not to be an expert, you're going to get in trouble for it. So we're very clearly supposed to say, we know the answer, right? We know, right? I know, of course I know, right? No idea what you're talking about, but I'm going to say I know anyway. But beginner's mind is saying, you don't. You know a lot. I know a lot about pathophysiology. I know a lot about these treatments. But I don't know anything about Bailey. I'm just meeting her. I don't know her. And I cannot know if she's suffering unless I know her, or at least enough. So the beginner's mind has to be an openness and readiness to understand that, of which I am not an expert. And so we practice a little bit about some curiosity statements. Anyone want to say, let's say we found that you're concerned I'm suffering, and said, geez, Bob, you seem to have a real lot on your plate. And I want to follow it with something. What might be a kind of a curiosity type statement? Anyone want to throw one out there? Go ahead.
Can you tell me more about that?
Absolutely. Yeah, tell me more about that. I'm here. I'm in, right? I'm in to hear more about that. Absolutely. Now, becoming more present and engaged, that's a little bit of the hooker, right? That's a little bit, I don't know exactly what you're going to do to be present and engaged, but you know it. When you're talking to someone else and they're not engaged, you kind of know it. It's like, you've got my phone out. That's a pretty good thing not to be doing. But the symbolic phone, you got it when people are distracted. So working purposefully to become more engaged. So that's what we're going to practice right now in a coaching sort of way. You guys still up for that? You could say no. Much easier to say no yesterday than today, isn't it? So we're going to set that up a little bit. And I want to introduce Vivian Jordan is a professional actor.
Standardized patient.
Well, actually, she's a professional actor and a standardized patient in the UVM Clinical Simulation Lab. And Vivian has been in the videos, and if we were to show you this, you'd recognize her all over the place, and I've really had an honor of working with her. So Vivian's going to get herself ready here. I did lock it. It's locked. And Bailey Fay is a third-year medical student who I've had the pleasure of working with now 3 times. You've done this before with me, and then a little bit clinically, and is such a good sport for being able to put herself out there in front of people doing this. It's really a lovely thing. So do you both have lapel mics on so that the group can hear you?
Mine's, yep.
So what Bailey and I are going to do, we're going to go into the other room. So now we're in the other room over here. Here's the other room. And Vivian is going to be in her room. And what we'll have just done is we'll have gone through a little bit of this mapping exercise, both in the big classroom type of thing, and then with you. You'll have had a chance to ask questions, see if this made sense to you, maybe come up with, we could brainstorm together some different statements that seem to make sense to you. Mm-hmm. And now now we'll get our game faces on. Ready? Mm-hmm. Game faces. Okay, good. So one of the things, Bailey, so we're about to do an interaction with the standardized patient. We're going to be, or you are going to be interacting with Ruth Gordon. And I'll say this loud enough so everyone can hear. So the story that you would know about Ruth is that she's a person who was admitted to the hospital about 3 or 4 days ago for what she thought was a pneumonia, and has just learned that, in fact, she has an advanced cancer, advanced lung cancer.
Slide off, yeah.
And she just got that news yesterday.
That's better. Okay.
And so your role is that you're your role is that you're a 4th-year medical student. I just promoted you.
Oh, gosh.
Dean gave me that authority. And you're doing your rotation with the internal medicine team. And you're just coming on, the team asked you if you would, and told you about the story, and said, would you go in the morning and get a chance to meet Ruth or Mrs. Gordon? Okay. And beyond that, you don't have any clinical purpose up in this scenario. But what I want is for you to practice this concept of turning toward it. And let me first ask if you have any questions about it. And I know you know this, but this can be intense.
Yeah.
Vivian's a very good actor, and this is a safe place to screw it up. All right. So we want to practice this. This is good. So what we're going to do is you're going to be with Ruth Gordon for maybe 3 minutes or so. Okay. I'll call time out, and then we'll have an opportunity for you to rewind if you want to try something else on for size. This is a good chance to do that.
Okay.
Good plan?
Sounds great.
Okay, all right, I'm going to back out, and you can walk in. I'll move your chair over.
Oh, okay, thank you.
I'll sit over here.
All right. Hi, Ruth Gordon.
Yeah.
Hi, my name is Bailey Fay. I'm a fourth-year medical student. I'm just coming in to talk to you this morning. Is it
Okay.
okay if I call you Ruth, or do you?
Sure.
Okay.
Yeah.
So, how was your night, Ruth?
Not real good. I didn't get a lot of sleep.
Yeah, can you tell me why? Do you know?
Well, I'll try to make a kind of long story short. I came in with what they told me was pneumonia. And they gave me antibiotics, and I started to feel good again.
Yeah.
And I figured I'd be going home today. And then last night, these doctors came in, and they told me that it's cancer.
I'm so sorry to hear that.
Yeah, and it's not good.
Yeah.
And I don't, they can't do anything for it.
Sorry.
So, I just don't know what to think, what to do, how to feel.
Yeah. It's really tough to get news like that.
Yeah,
Yeah. It's very difficult.
it's scary as hell. Oh, God.
Yeah. It's normal to feel scared right now.
I mean, I know everybody's going to do it, but you never think it's you.
Yeah. Sorry.
It felt so good yesterday.
Sounds like it was quite a shock for you.
Oh, yeah. I didn't expect that at all.
Yeah.
Not at all. I mean, I've had a cough and whatever, but I felt so much better yesterday. Okay,
Yeah.
how can that happen?
Okay, time out. Good. Whew. Got it. Okay, so we were just strategizing behind, so you guys couldn't hear. So what we would first do is before Bailey and I talk separately, I'll come over.
okay.
I'm coming into the room.
All right.
Right. And so, the first part of this, I'll just jump in. So, Bailey, how'd that feel?
Well, I always feel that I want to say something to fix it. And that's like my initial gut reaction is just to you're going to be fine. And in this situation, it's not necessarily the case. She's got really bad prognosis. So, yeah, it's really difficult to not do that knee-jerk reaction of you're going to be fine. Because it almost cuts her off, too. And
Wow, so you were feeling that. Do you feel like you were recognizing that in real time, that you were feeling, I want to say this is going to be okay, and I don't know what to do with that?
yeah, and I tried not to.
Yeah, right on. I wasn't able to pick up on you processing all of that in real time like you're doing, so that's quite impressive. So, what did you do instead of saying it could be okay?
I tried to just validate what she was feeling in that moment, and that it is normal to feel overwhelmed by something like that, and it is normal to have this, how could this happen? I'm so scared, and just kind of be with her in that moment, and give her just kind of a chance to unload what she's been dealing with by herself all night. So.
Right on. And you did that in front of 100 people. So we're going to come back to that in a second, but I want to ask Ruth.
Yes.
How was that feeling to you?
Well, she was very nice, I thought, but, she just let me talk and say whatever I needed to say and didn't tell me anything, which was a good thing, because I don't know anything right now. I'm just scared, and I don't know what I want to know, or I'm just all over the place in my head. So she did some very simple things, and I thought that was fine. Yeah. Although it's so hard, I look at both of you, and neither one of you can understand what I'm feeling, really. It's like men who, you know, think they know, or even OB/GYN doctors who think they know what it feels like to have a baby. They don't.
You saw the end of that take out the trash video? That's about where we're at right now. I'll give you a fist bump for that one, yeah. So are there any pieces of this that either of you wanted to rewind and try something different, emphasize a different approach?
I mean, one thing that I noticed is that at times I kind of wanted her to share more, but I wasn't sure whether to prod or just let her to process and come forward with what she wanted to share with me. So that was probably one other thing that I was struggling with, was whether to let it be and let her just share what she was willing to share, or whether to, maybe she needed a little extra push.
That's interesting, because
to
that was
open up.
my exact same thought. I might have liked to tell her
So you
a
might have
little
had
bit
like to have another
more.
push to pull something out from where you are.
Yeah, and I would have liked to talk a little bit more about some of my other fears, some specific fears and things.
Okay.
So we're on the same page.
Oh, good.
So Vivian, now we're back into Vivian.
Okay.
Bailey and I are going to step out and go in the other room,
Mhm.
and we're going to plan to do that again.
Okay.
And we're going to try on a little bit of that extra piece.
Great.
Okay? I'll give you a chance to get your game face back on.
Okay.
And we're going to walk into the other room.
Okay.
So it seems like both you and Vivian are thinking that you know, step one of that, of recognizing that she is hurting, that you were doing that.
Yeah.
And that you really had the awareness, the self-awareness to not do, oh, there, it's going to be okay, right? You know, sometimes that might actually feel good to some people.
Mm-hmm.
I have yet to meet that person in this setting, but it's always possible, right?
Yeah.
Do you have some ideas of how you might want to get at that next thing? So let's say you've done this interaction. Ruth has
Yeah.
told you she's scared. And I think you were both feeling like you wanted to go to the next step of what's that about?
Yeah.
What are some things you think you might want to say?
Tell me more about what you're experiencing. I mean,
Great.
open-ended.
Yeah, absolutely. And you could, if you wanted to go right at it. If she says, I'm scared, I'm afraid, you know, one option may be to say, hey, Ruth, see, how's that, right? That was a good example. It can be say, Ruth, this is scary. Can you tell me what's most scary to you right now?
Okay.
I'd really like to know that.
Mhm.
That's one possibility. And you might even not know what's scaring you most, but is there something in particular that's most scary right now? So you can go right after the scary if you want.
Yeah.
Or you can go after the open and tell me a little more about that.
Okay.
Either way you can in the moment, whatever feels best to you.
Okay.
Anybody else? Because what we'll do sometimes is have some of Bailey's colleagues who are doing this also be part of a coaching opportunity to be thinking, brainstorming together. Does anybody here have another statement that when Ruth tells Bailey that she's afraid, that you think might be a nice curiosity statement or something that gets a little bit more at things?
I have one fellow right there.
Good, I'm sorry, thank you very much. Yeah.
If she reached out and held her hand, or maybe she did that and I couldn't see it.
Okay, so one is holding hand, and I was recognizing that you were touching on her shoulder,
Yeah.
and we didn't talk about that this time. We can next time if you want.
Yeah.
Another one, yeah?
Maybe ask about her family,
Okay, and say more about that. What about the family?
if she needs any help contacting them
Okay.
or they're around.
Who's her gang and who's her support people, and are they available?
If they're not
Absolutely. Great, absolutely.
Yeah, I was just curious about how the news was delivered by these other doctors, and what reactions you might have had to how those doctors delivered that news, and whether she wanted to process that.
Okay, so that gives another space for, and that might manifest, yep, absolutely, that might be another option too. Other things I'm not seeing them, but,
There's one there.
go ahead, Chris.
Temperature of the patient's thoughts through the night since she was informed when she was, how her emotions went up and down. Is a way to get her to talk more about her feelings through the night.
Mhm.
It's been 12 hours since she was informed.
It's just a whole lot of time to pass to be thinking about new stuff, isn't it? Yeah.
Yeah.
So maybe what I can do, I'm going to stop for more at this point, and we're going to go on it. And I forgot to tell you one thing about coaching. And we didn't set this up as a contract, but one of the things we would do is say, Bailey, I only agree to do this with you if you'd agree not to take any of my suggestions. all right? Because otherwise I'm just ordering her to do something, right? And that's really not that's not fun for anybody. And and you might have a much better way of doing this. So these are all suggestions. You take them, you play with them, you use them or not, and this is up to you.
Okay.
So we'll rewind, and we'll go back in and do this, and I'll call timeout again, and we can just stop there.
Okay, sounds great.
I'll pull a chair in so you can come in the door.
Okay. Hi, Ruth Gordon.
Yeah.
Hi, I'm Bailey Fay. I'm a fourth-year medical student at UVM.
Okay.
Is it okay if I sit down and chat with you?
Okay.
All right. Is there any name that you prefer to be called?
Ruth is fine.
Okay. So tell me, how was your night, Ruth?
I don't know that I slept much at all. I don't think I did.
Okay. Is there a reason why?
Yeah, I don't know if anybody told you, but I thought I was going home today.
Okay.
I've been on antibiotics for what they told me was pneumonia. And then last night I found out that it's cancer and it's incurable.
I'm sorry to hear that, Ruth.
So I just don't know what to think, how to feel. I'm just so scared and upset.
Yeah. It's really tough to get news like that.
Yeah.
Can you tell me a little bit more about what's so scary for you?
Oh my God. I mean, first of all, well, there's two things. The first thing is not knowing what death is. Am I just going to disappear? Everything that I've known and loved, I'll never see again.
Yeah.
And then the other scary thing is telling my kids. You never want to hurt your kids. You never want to upset them.
Yeah.
And yeah, my kids are adults, but that doesn't matter. They're always your kids.
Okay, time out. You both are so good at this.
Thank you.
Wow. So I'm not going to go through what we did before, which we would in fact go through this again, a little bit of that. But just for time's sake, one of the things I just want to point out, maybe ask both of you, when that ended, where did the conversation feel like it was going any place different than it did last time?
For sure.
In what way?
Well, like I said, I finally got her to open up like I wanted to the
Yeah.
first time and just didn't know how to approach it. So this time it was really easy to get her to kind of open up. And then we had a direction, and we have, a conversation now about the struggles that she's having in terms of how to talk to her kids.
Absolutely.
And,
the family. Was it the conference about the family, right? Yeah, there you go.
So I don't know if you had any comments as well.
It was, it's just like anything that upsets you tremendously. You are upset, and yet it was a relief on a certain level to be able to tell somebody those things.
Yeah.
And so we had at least two things. One is the telling of the children. The other is the existential distress and meaning about death and dying and what it means after you're done living in this setting. And so it gives you a couple different places to maybe go to next. So I'm going to stop here, but just to acknowledge that there's lots of other things in this interaction that we could be critiquing, we could be thinking about, we could be talking about, but we don't. We try to focus on the one thing we're trying to do, unless something really, really, really big comes up that you guys both recognize, to not overwhelm the specific thing that we're trying to coach now. Tomorrow when we do it, we might talk about the touching on the arm. What was it, how did that feel? Where was that going? What was that conveying? Or every other dimension this is going. So this is just the idea of coaching. And I just want to thank you again for both you guys.
Yeah, I've got a robe on. Just turn the mic off. It's like you with your vision. If I forget the mic is on.
Yeah, there you go. Feel it. There you go. Oh, find my little clickers over here. So every medical student does that with turning towards right now. So we're all getting a chance to practice it. And it's remarkable the things that come up, and it's remarkable the things. It's lovely for me to get a chance to see all these different human beings saying and doing things that I can put in my little toolbox and say, that really worked wonderfully. Let me add that to some flexibility for me. And a safe place for them to practice it, because this, not everybody turns to it so well as Bailey does. And it takes some time to be able to be frustrated. I'm not sure what that emotion is picking up. I don't know what to do. I need to practice this. And it's a safe place to practice it over and over to at least feel like I've got a little sense of it. So I'd like I'll take just about 10 more minutes and take this coaching thing to the next level. So if we're going to disseminate high-quality communication, one model is when people are actively engaged in a learning curriculum like medical school or nursing school, which showed you what coaching can look like. But if we're going to do this for our region, the Adirondack region in New York and all of Vermont, we're going to have to, if we want to do this for clinicians in practice who are caring for people who are seriously ill, we're going to have to acknowledge that conversations are not something that has, serious illness conversations, are not something that's been really rewarded in medical practice for at least the last 60 years. Conversations take time. They don't get reimbursed well. There's been a whole set of symptoms, system-level stuff that has, that our current group of physicians who may be phenomenal communicators are in a setting that hasn't valued it for a long period of time. So our opportunity is to pull away that callus, open that up a little bit, let all of those skills that people have out, and coach us again with our colleagues who want to be communicating well and who can, if we can provide the culture change and system change to make it happen. So the first steps we're doing is to acknowledge that these skills we're talking about, yes, I'm a palliative care physician, I'm also a family physician, I'm not practicing full scope family medicine anymore, but I'm no different than the person I was when I did. I have a little bit more skills and experience in some more complex settings, but I have a different fundamental job right now. What we're recognizing that any way to scale this up to get our whole region has to acknowledge that palliative medicine is really, this is good medical care, right? And it's not something that a specialist needs to do or should do necessarily, but everyone should. So we have generalists and specialists. You'll see that. So when we hear the term palliative care, oftentimes it'll be in generalist or specialist language from us and other places. So what we're doing for the culture change is we're going to do what we just did with Bailey, maybe not on the same level of turning towards or mapping a new behavior or a new conversational moment, but maybe remapping it, saying what's something that comes up in your practice in these types of conversations that we want to think about or talk about. And the areas are frequently things like prognosis that physicians have not had. There's plenty of research to show that being a physician, you get a lot of training and talking about what to expect in prognosis. And then we learned how to start curing stuff in the early 1900s. And then we learned how to diagnose stuff. And so diagnosis and treatment took over so dominantly that we lost the ability to talk about prognosis or modeling or what it looked like. And so that's an area that oftentimes we're needing to coach up again and practice that a little bit. So what we're doing is we're bringing in some experts in training people to coach. These are three palliative care physicians who put together their world-renowned communication scholars, put together this nonprofit that is a train the trainer program. So we're going to train 24 UVM faculty to be communication coaches. And most of them are going to be from some palliative care affiliation in our network hospitals, but not all. And so I'll show you their names in a minute. But this is going to be for both generalist and specialist palliative care from all of our network hospitals, and for multidisciplinary teams are going to become our coaches, our UVM army of communication coaches. And this is them right here. I don't know if you might have a chance to recognize them, any of their names. But this is our willing group of people who have good skills at baseline, who want to develop their skills to coach communication. And we're going to bring in this group Vital Talk starting next week, actually, to teach us how to do this, including myself. In May and October, we are going to, 30 of us actually, we're sending a few to Aspen where they usually hold it. That was not a hard sell, to be honest. And we're covering their tuition expenses to do this. And what the faculty have agreed is say, okay, if you pay this company to come teach us, we'll offer up 1 or 2 times a year, we'll teach a one-day communication workshop called Mastering Tough Conversations, which is what the Vital Talk group teaches us to teach. And so what we're going to do is every month for the coming 3 years, we're going to offer a one-day communication workshop around our network for any clinician who wants to learn to communicate in serious illness. And so we're going to offer that for 3 years, and we have the capacity to train up 432 clinicians, whoever's interested.
Will you be doing that here?
Yes, we're going to do it here and all around our network. So we're going to, I can't tell you the sites because I don't know them right now, but we're going to go to where people want us, and we're going to go maybe a little bit to where people don't want us, but that doesn't always work super hot. But what we also have to recognize, so what this does is adds to some culture changes and readiness for some of the communication awareness, some of the communication skills, and some of the readiness. But that alone isn't going to do it. What we need to do is change the systems within which we work to value communication, to make it feasible to have these conversations, to know what to do with them when you do. So this is what this next group, Ariadne Labs, if anyone has heard the name Atul Gawande, he runs Ariadne Labs at a Harvard School of Public Health. He and Susan Block have developed an intervention called Serious Illness Care Program, which is to implement systems change to value communication from a system point of view. And what that means, and they've had extraordinary success in Dana-Farber Cancer Center in Boston, primary care practices in the Boston area, in Texas, the whole UK, the National Health Service has hired them to train their docs in England. And they're having phenomenal outcomes for patients who are seriously ill with respect to quality of life, goal concordant treatment, and extraordinary success with the clinicians who are feeling more meaning in their work, less burnout, and all the things you're going to want to see from an intervention to support this. And what they focus on is not necessarily coaching up the flexible communication skills like Vital Talk's expertise is, but they give you a roadmap, a conversation that isn't about a specific decision. It's not designed to say, do you want to do X, Y, or Z? Or if this happens, then what do you want to do? But rather a conversation all designed for me to understand who you are and what you value, and what are some of the trade-offs in your current situation that would be meaningful for you. What does suffering look like to you? And to document that in a systematic way so that when and however you need it, we can add to that as we learn more, and we can act on it. And so that means identifying people who are seriously ill, triggering the clinicians and patients to have a conversation, to change the office system so that maybe it can happen. Maybe that means booking it for a procedure, which gets you a little more time. The procedure in this case is a conversation. And then backfilling, rewarding them with enough dollars so that it's not a loss of revenue that makes them go bankrupt. So you have to actually be aware that money is an important thing to think about. To be able to document a conversation in a systematic way so that people know what they're looking at when they want to go on a medical record and see, have people had this conversation? What does it look like to them, at least last week? And how to act on it. If I find something come up in a conversation I don't know what to do with, instead of ignoring it and never having that conversation again, we're going to have a teleconsult back up to our specialty palliative care practices so that clinicians can reach out to us for a hotline form of coaching and feedback and advice, and direct teleconsult with patients and families who want or need a specialty consult for the FAR. So this is what this group is doing. And we're going to do it in five pilot practices, because this will be an expensive intervention. But if it works as well as it does in other places, it's going to be extraordinarily worth every penny. And so what we're going to do over the next 3 years is have the Vital Talk things going in sync with 5 pilot practices with the Ariadne group. And at the end of the day, we're going to also have to do this other thing called measuring quality. Has anybody heard about health reform? Anyone heard more than they ever wanted to about health reform? So we're in an exciting place right now that is really tackling something that nowhere in the country has done yet. And that is to say, can we care for a population of people and reward ourselves for doing it well, not just doing more of something? And that's what we have an opportunity to do in Vermont. But what that requires us, which is a really uncomfortable thing, because this is a new thing, is, well, what does good look like, right? If we're going to incentivize ourselves to do something of high quality, we want to measure something that's of high quality, or else we're incentivizing us to do, if we put the bar so low, it's not really going to be meaningful. If we put it so high we can never achieve it, that's not going to be helpful. Or if we put the wrong bar up, it doesn't matter if we go over. So what we're looking at in some of our research is saying, okay, if we're going to measure stuff, it has to be feasible to do without getting in the way of normal practice. If it's going to require people to stop what they're doing and add another 2 or 3 minutes onto whatever they're busy, it's not going to happen. Or it's going to happen just with a select bunch of people. Oh, I had a really good interaction with you. Would you mind filling out my survey today? That type of thing can be concerning for us when we're trying to measure quality. So we want to try to figure out how to do it as unobtrusively as we can. So what we're studying is, are there things in a conversation that are going to be indicators of a high-quality conversation? And those may be the things that predict good outcomes, people feeling heard and understood. It might be things that indirectly measure an important attribute of a conversation. And we can do it automatically. Does anyone have a cell phone here? Has anyone talked to Siri in the last year? She's getting really good at this. 5 years ago, she would send me to the Chinese restaurant when I was actually asking, how to get home. But the technology around not just voice recognition, but pattern recognition and speech signals is getting super, super good. And so what we have here at UVM is a group whose expertise is understanding complex systems. And the systems where they've developed their expertise has primarily been the environment. Trying to understand this complex ecosystem within which we live requires a heck of a lot of computational power and learning from a machine point of view. We think of conversations ecologically too. And so what we've partnered with our colleagues in the UVM Complex Systems group, Maggie Epstein and Donna Rizzo, and Victoria Manukian, are part of our lab, and they're all computer scientists who focus on artificial intelligence, machine learning. I don't know any of that stuff, so it's really lovely to work with people who I can tell them what I really want, I can hear what they're talking about and say that's really cool, and they can create a slide for me to say, I want to show some people what we do, but I don't know how to explain it, can you show me a slide? So these are the pretty pictures. There's a lot of ways in which a speech signal can be seen by a computer, and what this is just showing is there's lots of ways to analyze it. Now, for the turning towards thing, is there anything you can imagine that a computer might be able to see that might be an indicator of compassion or turning towards or a presence and engaged in a conversation?
Are you working with a video? Can you do something about mirroring body language?
No, we can't. It's all audio. The video is fascinating, and we thought about it. To reach the state-of-the-art research in video stuff, you need a place that's got multiple cameras so you can train on people's eyes. And we just couldn't figure out how to do that in a hospital room without being so invasive. Wonderful idea.
Change in voice?
Sure, so voice tone, good.
Moments of silence?
Excellent, yes. It's actually when you're not talking that we can find some really important indicators. And so what we looked at for turning towards is this concept of Joseph Bartels now he's a family medicine resident. He took a year off of medical school to work on our research project and get an MPH. And he studied silences. He's a musician. He was fascinated by this. And so we developed a project with Joseph about trying to identify silence. What does it sound like from a musical point of view? And what we learned is that he could train the music students again to identify 3 types of silences very reliably. One silence was distraction. And actually the way they got this in here was because you could hear computer keys, because this was an outpatient office. Another one we just called awkward because we weren't sure what to do with it, but didn't seem to fit any nice bucket. And the third we call contemplative silence, or eloquent silence. He's calling it eloquent here. The contemplative silence is when there was a purposeful break in that conversation to allow something to be, something just happened. And we're giving it a little bit of space before we address it. And so those contemplative silences, we're learning that the computers, right now, this is an example from one of our audios. We can find silence very reliably. Now that sounds silly, right? Teaching a computer to find silence, that's pretty dumb. Sorry to say it that way. It's actually not, because the hospital room is anything but silent. So what we have to do is train the computer to find conversational silences. Know when that's actually Oprah on the TV next door, or when that's a machine going beep, or when that's the door slamming. When is it a conversational silence? So we've been able to, Victoria Manutian, who's a master's student on our project, has identified a pattern to speech signals that can reliably identify silence. And now we're working on, can we identify the shape of those silences? We take the sound in and the sound out, like about a quarter second in and a quarter second out. That's what we did with Yosef, is that the shape of those things look different. And so right now we're in the middle of trying to train our computer to be able to identify contemplative silences. And wouldn't that be lovely if we could incentivize? Now, I might not tell physicians that it's silence, because then I might sit there and be silent, but rather we're going to try to measure something that is a real, relatively accurate measure of turning towards in compassion, and we're going to train in compassion training and be able to measure how well that's happening. To me, that's an idea worth pursuing. Now, I want to leave you with another big idea, because I think you have insights that are going to add to this, either in this room or when you leave this room. And this is Susan Block, who is the director of the Serious Illness Care Program, says, where we are now is that we do some of the right things for some seriously ill people some of the time. And where we want to be is that we do all the right things for all people all the time. And I think that's feasible. I think that's feasible, and I think we're working towards it. So I want to leave with that imagination, and to welcome you to imagine with me, and to welcome your thoughts. So we have about 15 minutes. Thank you for your attention. I also want to welcome Bailey and Vivian to be part of the Q&A. So if you have questions for them about this experience, please feel free to ask that. And they agreed to fill that role as well, so they're not surprised by that.
Up here.
Please, yes.
Can you go back to the slide with the musical score on it? Just
Sure.
Describe what that means.
That?
How you use it.
I'm trying to get another. So the question was, what does a musical score mean? Actually, I'll pass that over. You want to take this and pass around and ask questions? So what it's recognizing is that we did a separate paper, I didn't show you a picture of this, is where it wasn't the eloquent silence one, but it was musical notation. One of the things we found is one of the things we try to measure is expression of emotion in a conversation, like fear or sadness. And when you look at the lexicon of the words, it manifests sometimes in words. I am sad. Okay? Doesn't always happen that way. Or it happens in the voice tones, like, I'm not going to go Google, but the change in pitch, the change in tone, and rhythm, that all happens. But what we found is the current ways of identifying were falling a little short. So we had two of our music students, we love our music students, who are now getting their PhDs, and one of their PhD projects involved, I think I can turn a conversation into a symphony. I think I can do it. So I'm going to take all the individual speaker notes in this and plot it musically on what the sounds are, and turn one lovely conversation into a symphony. And so we're still trying to create it and actually get it played. But what it did is we wrote an academic paper on the thing we call emotional storm. Is we could see the emotional storm brewing sooner on musical notation than we could on speech pitch tone recognition in our current methods, which was saying this is another way that we can think of conversations that might be able to find important moments using a musical. So that's what the really meaning is. We're trying to translate the same idea to the sounds going into a silence and the sounds coming out. The musical features of those might actually be quite indicative of what's going to happen.
Well, we're
Back here.
Oh, thank you.
I don't need the mic.
Fire teacher.
At what point might a clinician read an advance directive?
When might they say read it?
Read an advance directive.
When might they read it?
Yeah.
Anytime there's one there. I mean, I think that,
But
and I don't
they
mean
read
that
it before
truly.
they go in, or?
Oh, when, so, let's imagine, so in like in a Vivian situation, like in a hospital acute care, are you talking in the office? So for example, let's break down the advanced care planning piece. I didn't show much of this, but in case people had questions, I did something to make me all dizzy. There. So this is Gwandi's group and some of our team contributors starting to break down what do we mean by conversations. It really kind of some different pieces. So what you're talking a little bit is advanced care planning, which is usually in advance of serious illness or not necessarily in crisis. Is that there's some preferences and some values and some things that we can really say are important about me that I think are going to be durable in settings to come. And that might be one kind of vague definition of advanced care plan is, which a major component is identifying who's your person, right? Who's going to speak for me if I can't speak for myself with respect to medical decisions. So we look for that personally anytime we're seeing somebody, of course. I would say that I guess I've lost track and I'm not answering your question. I'm doing a poor job of answering your question. If I'm going in to see somebody who made an appointment for their pap smear, I might not be thinking about looking at the advance directive before I walked in. For example, if I have someone who's coming in for a serious illness and I'm already concerned or aware of that, I might check and see what is there. More often than not, at least in my practice when I was doing office-based family medicine, I'd be more likely to either go out of the room and look for it at a time when it was important to recognize. Even if it's to say I don't see one on file, did I not talk to you about this? Let me share a little bit about what this is about and how to learn about it.
Okay.
Is that number here?
Go ahead.
I'm in the dark. You talked a lot about verbal and conversational strategies for understanding people better, and I was wondering if you've encountered or if your group uses any.
I'm sorry, say what?
Yeah, I was wondering. Yeah.
Take the mic.
Yeah. You talked a lot about kind of verbal and conversational strategies for kind of improving communication. Have you used any more visual, either worksheets or any sort of visual technologies to help get at people's goals and help them use another kind of modality besides speaking to communicate their wishes?
Yes, two ways. One is sometimes we're seeing people who are having cognitive challenges from their disease that might make it hard for them to read the way they're used to reading, or they might need other cues. So sometimes if we're using, if we're doing pain scales, for example, we'll want to make sure that there are accompanying pictures, at least that might anchor a little bit. If I'm explaining something that is important for a person to understand, let's say that they felt like it was important for me to understand what's happening inside my body with this, I'm likely to draw on something to show my understanding of what we're looking at, if for no other reason than to say, are we in the same ballpark here? That might be something we're doing a lot of. So I use pictures a fair amount for that type of thing.
Thank you.
I don't use a lot of pictures for probability stuff. Just see in literature about saying, I can show a picture of 100 people and this person has, if I try to say the probability of something happening, I haven't found the probability pictures to be very useful in the setting that I'm doing most of my counseling.
There were 2 points in the conversation that you were having that triggered some things for me. In the first conversation, you talked about you had been through the night after having been told that this was a more serious problem than you were anticipating. And what I wanted to know was at what point in the prior day you actually found that out? Was it toward the end of the day? And if it was, what's the medical staff responsibility for making some kind of response, knowing that Ruth is going to go through the night? And the other one related to when the family conversation came up in the second conversation, because I think part of the problem that we have culturally is that we don't talk within families a lot of times about what I as an individual might like my family to know about my feelings when my end of life approaches. I think we do a lousy job of that. And so I'm curious to know how each of you felt about those 2 points and whether there was more that you wanted to do. And how is the medical process going to deal with the fact that there's one thing that we know about every individual who's born, and there's only one thing we know for sure, and that is that they're going to die. And so how do we bring that knowledge together and help people to talk about it within families?
Well, I guess I will, since the first one had more to do with me specifically, in the scenario, in the way I see it or experience it, is that the doctors, a team of doctors came in, oncologists, and they talked with me, and they were polite, and they were not brusque, they weren't whatever, but once I found out what was really going on, my mind just went on this crazy merry-go-round, and I really didn't hear much of anything else. And so during the night, yes, nurses came in, how you doing, sort of thing, but I felt very low. And
Okay, it's on. So I think, well, for me right now as a medical student, I think I serve a very unique role because I do have a lot of free time during my day to go sit down and talk with patients and talk about what they are actually experiencing and what's going on for them. And I think that it's a critical role to play, and it's honestly really rewarding just to be there with them because it is difficult, and some of them, their families are far away or they're en route, and it gives me the opportunity to kind of listen to them until their loved ones are available or there.
So I'll take the second question. So I'll take the second question was, I think, about it was about how you make space a little bit for
How do we get families
to talk
prepared for reality?
So there's the couple of things that I like to do, or I've found it's been helpful, is to recognize a couple things. One is that in the times of intense suffering, or nearing when someone's going to die, a lot of the ways they have interacted with the people that are important in their lives might really be working well or not well the same way they used to, or they may be a completely different kettle of fish now. And so there's two different ways I think about it. One is to make space. If you are going to want to talk to your loved one about this and want to have an opportunity to do so, I can help facilitate that with you. And I may ask you very directly, Vivian, say, Vivian, it seems it's really important for Ruth. Was it Scott, was your fiance?
That's Sean.
Sean. So what comes up in the conversation that I videoed with her was we talked about existential distress and talking to their family and the importance of wanting to be able to talk with Sean about this because they hadn't talked about it. So a little bit of our strategy was, well, let's think about what are the ways you'd like to do that. And we had decided that Vivian wanted to be around for kind of the high-level stuff, like kind of what's happening and the things that are important. And then she wanted Sean and I to go have a coffee, and gave me permission to share some of the things that she wasn't sure she felt she was able to say to him right now, as a step one. And then offer space to talk about it later. And the reason I feel okay doing that is a couple. One is that if these relationships are going to grow in a way that is healthful and addresses suffering for this person and that person, we want to make every opportunity for that to happen. But it might not, and it may not need to. So my vision of what reconciliation looks like, or what peacefulness looks like, may not be what yours looks like, and it may be very not what hers looks like. And so we try to take our cues to make sure we have the opportunity, but also honor it when don't think that's really going to happen, and we still need to turn towards us in a way that can work. So sometimes it might be like, I can't talk to my mom about dying. I'm thinking of a gentleman I took care of who was in his late 20s and he was dying of cancer. And he's like, I just can't do it. Every time we do, this is what happens, and it's not healthy for us. So what we agreed is when she's there, we're going to talk about joyful moments in their relationship and what's been important to them. And as soon as she leaves, he asks, will you just come back? And I come back and he say, death, 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 dying, dying, dying. Okay, now we're done. And then I come again, right? And so that was kind of my role. It was to say, okay, this had to be a space, he needed that, and he and his mom needed that, and it just wasn't going to happen and all together. I guess, is that answering your question in any?
Somewhat.
Yeah. Yeah.
There's a few of us that have been involved in hospice and palliative care education for the public for 25 years. And to answer one of your things is to have that conversation numerous times before it's an issue. My brother says, can you get a happier hobby? But trust me, when someone gets sick in the family, who do they call? And what should I say and how do you do it? And it's about having your stuff ready. And once a year, I have a red file, and my daughter says, "What's the boat gonna sink?" I said, "Well, it might." And we go over it and just in the big picture. And I'm healthy, I'm young, I'm not dying, but tomorrow's something else. So it's not the first time when they walk into a hospital room with you and you're in the bed and you just had the diagnosis. You don't have to have it then because they know. They know who your person is, your agent, and they know what your wishes are. So it's much easier sitting over coffee, doing it in the morning, not at night when you have the scary dreams, saying, this is what I would want. I don't want you to have to make the decision for me. I want you to know what my decision is and you just carry it out. It takes a lot of pressure off your kids if they know that they're not making the choice for you. They're just carrying out your wishes when you can't speak. So.
Thank you very much. Thanks for your work.
Some more.
Take one more and then we'll wrap up.
I was just asked, what could be done to introduce the notion of palliative care maybe earlier to patients? I mean, it's been my experience that palliative care often gets consultation in very, very advanced cases of serious illness, and families are, really that equate this with, the last days of life with hospice care. Relieving suffering could be so much more than just dealing with, the last week or two of a person's life. And I'm just wondering what your thoughts are, maybe broadening the notion of palliative care for the general public and to physicians and medical personnel.
I'll give you 3 answers, and none of them are going to be super. But one of them is that to what we always want to do when we're trying to change something. You've identified something that we say we'd like to change. And it's pretty culturally embroiled in lots of us in different ways to not talk about something, particularly something scary like dying. And if you're a physician who's acculturated to, my job is to cure this disease, and I don't want to talk about not being able to do that. And if I have to call someone who might indicate that I might not, anyway, that becomes an uncomfortable thing for lots of reasons, is we got to think about both the culture change and the system change. And I think about system change a lot. You want to make the easy thing the right thing, right? And so the default might be, gosh, in electronic medical record, for example, we think about ways to trigger stuff that we might not otherwise think about. Like, gosh, I recognize that you have multi-morbidity with lots of complex illnesses. And we oftentimes think about if your clinician would not be surprised if this person died the next couple of years, like you're that potentially sick, that, gosh, that's a good at least trigger to say, have you thought about having a chance to sit down in a non-crisis mode with some compatible care? That's one way to do it. The other way is to say, this is just something we should all be acculturated to do. And so we bubble this up into normative medical practice without having to call it palliative care. It's good care, right? And so that's my ultimate goal, is to change the norms and what it means to care for seriously ill people. And we're going to have to do that from all the participants in the conversation. It's going to be from us in the clinical side being ready and willing and interested to promote meaningful conversation. This can be for our culture to be able to say we're going to talk about it and make that okay for our doctors to do and not be angry at them for bringing it up. Because some docs really get a lot of negative feedback about the perception that I'm abandoning you because I'm not talking about cure anymore. That can be a really scary thing for doctors to do, for patients sometimes, so they remember that. And so we need to all kind of normalize the idea. We're talking about some hard stuff, and we really want to do it meaningfully. So that's the most important thing from my perspective. Let me just, I'll stop there.